Thank you, Dr. Chang. Let's talk now about some surgical strategies in KC. First being intracorneal ring segments or Intecs. Now, the intracorneal rings, if you picture a contact lens, a rigid contact lens, punch a hole in it, and cut it in half, that essentially is the appearance of an Intact, as you see here. There's two semicircles of a donut, so to speak, of a contact lens-like material. Now, they've been used for the past couple of decades. First, were approved for the treatment of nearsightedness, and then underwent another approval by the FDA by a humanitarian device exemption for treatment of keratoconus. They're rather small. They have a diameter of about 6 to 8 millimeters, and it is the thickness of the Intact that determines the amount of correction that you might get. And these vary as you see right here. Essentially, larger cones are going to command a larger Intact segment size. Intecs provide a structural support for the weak part of the cornea. You can see them here in place within the stroma, or the meat of the cornea, so to speak, and you can see how they go around in a donut, circumscribing your keratoconic cone in many times. The primary goal of Intecs is to make the patient who is intolerant of contact lenses better tolerant of the lens. We also are looking to get a better glasses corrected vision to make you more tolerant of glasses correction with better visual quality. Oftentimes we're trying to balance the two eyes, and sometimes we'll get an improvement in uncorrected vision without your glasses or your contact lenses. The Intacs procedure starts with a laser type of procedure, much as we do in LASIK. You simply will be looking up at a laser, and a ring will be made, a channel within the cornea through which the Intecs is placed. The Intecs are then inserted, and postoperatively you'll use an antibiotic drop and an anti-inflammatory drop for a week afterwards to keep down any infection or inflammation that potentially could occur. Frequently, this does not require sutures. It's dependent on the individual case and the individual position of the Intact, but more times than not, we don't need to use sutures in the Intecs procedure. Here you can see the small entry site through which the Intecs is placed, and here you see the Intecs in the actual eye. The goal of Intecs primarily is to make the cornea more symmetric. The problem that you have in KC, as everybody's discussed already today, is optical static. You don't have a cornea that can be corrected by glasses because, besides nearsightedness and astigmatism, there are irregularities which form a visual static in your visual system. So with Intecs, we're taking a cornea that is bowed out, and you can think of it as pushing the cone down, with the primary goal to make the cornea more regular, make it smoother, and to cut down on visual static. Now, to do this, we may use 2 Intecs, or we may use 1 Intact, depending on the shape of the cornea. Here you see a keratoconic cone that's centered essentially within the cornea. So again, we're starting low, then going high. We're seeing the cone here, and coming down again. Here the cone is about 63 in height. So in a circumstance like this, we would use symmetric Intacs, either top or bottom and side to side, and you can see what it does here. It has taken the steep central area, and this is what we call a difference map. This is the effect that the Intecs has had, and it has flattened the entire cornea. So you have a cornea that's gone from that configuration to that configuration. In the second example, you see a keratoconic cone that is more asymmetric. So rather than being steep in the center, like that, it's flat up top and steep down below. You can see that here in this map. So once again, flat up top, so we're starting low and going high. And in this case, we'll use either an asymmetric size, a big one below and a small one above, or we'll use one single Intecs. And when you do this, you get an asymmetric change in the corneal shape. That is, you flatten the lower cone area, so you see that area is becoming bluer, and it has the effect on the other side of the cornea to steepen it a little bit. So in effect, you're making the cornea more regular. By making the cornea more regular, you're optically better, you get less visual static, and a better optical outcome. An example here of symmetric Intecs. You can see that in our studies we found a flattening of around 6 diopters. So again, remember, normal 40 to 47, KC's 47, could go upwards of 90, and here you can see the generalized flattening effect of the Intecs procedure. This is a group of asymmetric inlays, fatter below and thinner above. Here you can see that the flattening is even greater, so we're getting a lot of flattening in the cone area, and again with the concomitant steepening above, that's giving us a more regular cornea. So here's before, here's after. You can see that the red has shrunk. This is an example of a single segment. So this is just one Intecs below where the cone is. Here is the steep area, the flat area to start. We place the Intecs here. You can see the change. So there's been a lot of flattening below, on average of 7. And you can see afterwards how the corneal topography has become dramatically more symmetric. So looking out of this cornea, you're going to get a couple of focal points because they're going to be focusing in different areas. After Intecs, you can see that the focus is much more symmetric and even over the entire surface area of the cornea. Here's a patient who had combined Intecs and collagen cross-linking. So preoperatively, you can see here that best vision was about 20/40, uncorrected vision 20/60. This is before and after cross-linking, so not an awful lot of change, as we expect from the cross-linking procedure per se, but the cornea here has been stabilized. Then we placed a single segment Intecs below, and you can see the marked change in the corneal shape. People always ask, are Intecs permanent? In general, we hope so. The chance of needing the Intecs removed typically is early on, first 6 months or so after the procedure. About 1 in 20 patients need their Intecs removed for reasons such as inflammation or infection or other things that we don't like about it. But once it's in there and stable, typically it will be retained in the long term. As Dr. Tannen was saying, if you need cataract surgery 30 years later, the Intecs is still in place, we're going to leave that in place there because it's still having its effect on making your cornea smoother. Here, for instance, a patient, though, who came in late with double vision. This was the picture beforehand. The patient had double vision because we still had a lot of steepness here and flatness there, and this is where the Intecs were. So in this case, for instance, we took out the Intecs, replaced one down below there to follow the corneal curvatures, and you can see how we got a very nice result, and again, making the cornea more symmetric. So when you're thinking of Intecs, think of corneal symmetry, making the cornea optically smooth. As I mentioned in that last case, we can combine Intecs with collagen cross-linking. This is because, in essence, they are attacking keratoconus from two different sides. The goal of the Intecs is to make your corneal contour better, improve the symmetry, improve the contact lens fit, improve the glasses' corrected vision. Doesn't affect corneal stability, however. The goal of cross-linking, though we do see beneficial side effects of improved vision and improved corneal contour to a limited degree, the goal of Intecs really is to strengthen the cornea and prevent progression. So the thought is if we can in some way combine the two, we'll get the stabilization effect of cross-linking on one hand, and we'll get the corneal smoothing effect on the other hand. So we've been doing a clinical trial combining Intecs and cross-linking with the goal, number one, to see how they work together, to see what kind of effects we're getting, and number two, to see should they be done together in one setting or should they be done 3 months apart. So there are two things that we looked at. To answer the second question first, it doesn't matter when you have the two procedures done. We are getting equivalent effects whether we do them on one day or we separate them by some time. When we look at different size Intecs, similarly, we don't see an effect of timing of the procedures, but we do see effects of properly assigning the Intec size and the Intec configuration to your particular situation. So we need to analyze your corneas carefully, analyze the corneal topography carefully to make the proper surgical plan of size of Intecs and where to place the Intecs. We can also use, with Intecs or cross-linking, an adjunctive procedure called conductive keratoplasty, or CK. CK operates via a radiofrequency approach. So using a small probe, which is placed into the cornea, it causes a localized contraction of the corneal pancakes. And what this does is it helps to reshape the cornea in addition to the reshaping that you get from Intecs. It's an FDA-approved procedure for farsightedness and reading vision, not FDA-approved for keratoconus, but we've done many studies of this and we can adapt this for KC in a number of cases. You can think of the cross-linking as making one area of the cornea focally steeper. It's like tightening the laces on a football to change the football shape. So if we find an area of the cornea that is loose, so to speak, where we want to tighten the collagen fibrils, we can apply the Intecs spots in order to do that. And often we'll do that, for instance, we have an Intecs below and we want to steepen a little bit above. One example of a patient with KC who had conductive keratoplasty alone, and you can see before, we're trying to push that cone up and flatten it. Here are the CK spots, and after with a good effect. So the CK is essentially used to reduce irregular astigmatism in the keratoconus cornea. We can use it with Intecs. Most frequently we use it after the Intecs procedure to enhance the effect. Here you see CK spots. Here you see a before and after again using the CK procedure to decrease the astigmatism. This is a patient with a fairly substantial cone inferiorly. A patient first had two symmetric Intecs, and that reduced the height of the cone rather substantially to 60.4 to 47 a 0.8. But we also found that the top of the cornea was a little too flat compared to the bottom of the cornea. So though we flattened the keratoconic cone, we still had too much irregularity and wanted to improve the corneal symmetry. So we removed the top Intacs, just went with the single, added the CK where the Intacs had been, and you can see here now how we flattened below the steep area and we steepened above the flat area to give a much more regular cornea that could be then more easily fit with a contact lens. What else can we do? People always ask in KC, can they have laser refractive surgery? Indeed, many patients, as I mentioned before, are first diagnosed with keratoconus when undergoing screening for procedures like LASIK. They've had long-standing nearsightedness and astigmatism. The KC's never been diagnosed. They come in to have LASIK and are discovered really to have keratoconus. So LASIK itself is the most commonly used vision correction procedure. It's now been around for 20 years. The theory of laser vision correction is that rather than putting on a contact lens, we're removing what you can think of as a tissue contact lens with the laser, but the optical principles are the same. Now, the removal is done with what's called an excimer laser that scans a number of spots, and each time the laser hits the cornea, a little bit of tissue is removed. And the excimer laser can remove tissue from the cornea very meticulously without damaging it. So this is one of the first pictures ever of an excimer laser having been used. Is about 1987. And what you're seeing here is a scanning electron micrograph of a shaft of human hair. And you can see how a notch of the hair has been removed, but the base is normal, the sides are normal, there's been no other damage made. This was an early laboratory excimer laser treatment where they removed essentially that tissue contact lens with great success. So regarding general laser vision correction, there are two ways we go about the procedure. Either a LASIK, which makes what we call a LASIK flap, or the photorefractive keratectomy, LASIK, ASA, a procedure which uses the laser without a corneal flap. So the first step in LASIK is the creation of a very thin pancake of the cornea which holds the surface cells in place for fast healing. In order to do the laser treatment, we have to get down to those pancakes of the cornea that are what's the difficulty in keratoconus. And to get there, we can lift that corneal flap, treat, put it back down, and the healing's quick because the surface cells don't have to heal back. The alternative is the PRK procedure, where we don't make the LASIK flap, rather we remove the surface cells. So it's like removing the tiles on the floor before working on the floor. Outcome's the same, but the healing process is slower in the PRK procedure. Now, all of that having been said, laser vision correction for the most part is contraindicated in keratoconus. Why is that? Because no matter what we do, with laser vision correction, we are removing tissue from the surface of the cornea. And by removing tissue from the surface, we are likely decreasing the strength of the cornea and making it more susceptible to progression in keratoconus. So that's why LASIK is not something KC people should have done. But there are some modalities that may still be available to you. The first is what's called topography-guided PRK. This is something that has been used overseas for the past several years. It's recently been FDA approved in the US, and we should have availability of this technology come around February or March. But basically, what is done in topography-guided PRK is we take the corneal map, feed it into the laser, and then the laser is able to remove a little bit of tissue to make the cornea more symmetric. Again, the goal here is not the goal of LASIK, which is to get you out of glasses and contacts. Rather, the goal is similar to the goal of Intacs, which is to make the cornea more symmetric. So this is a patient of ours before having anything done and after cross-linking. You can see a slight shrinkage of the cone, a decrease in the steepness from 60 to 58, and good stability afterwards. This man went overseas and had the topography-guided LASIK, topography-guided PRK procedure, and you can see how the cone has shrunk even more. So a pretty good result here. We've now gone from 60 to 58 to 52 on the height of the cone. He still had difficulty with a lot of double vision. So the next step that we took was to place an Intecs below in the still steep area. And you can see here how these combined procedures have led to a cornea that is very, very symmetric, with an overall flattening of the cone, if I can read it correctly here, of 17 diopters. So he's gone from about 61 to 44, which is very close to normal. Now, of course, he had a really good result from all of these procedures. His walking around with very good uncorrected vision. Clearly, it's not for everybody, but it's a very hopeful sign for the kinds of things that we will be able to do for keratoconus. As I mentioned, it was just approved in the US, and we hope to be performing these procedures come this spring. Another potential use of the laser is in the PTK procedure. This is called phototherapeutic keratectomy. It can be used in patients with superficial corneal scars. Sometimes patients with keratoconus have scars, particularly at the tip of the cone, or nodules that can affect contact lens wear that in some circumstances can be shaved down, so to speak, with the laser. And also in some cases we may use the laser to treat irregularities of the corneal surface. As we mentioned way earlier this morning, the corneal surface cells can actually act as a mask, a kind of spackle over the cornea, and by using that and using the therapeutic procedure with the excimer, we may be able to smooth the cornea to some extent. And finally, the excimer laser can be used after corneal transplants. Once corneal transplant is done, as Dr. Kronstadt is soon going to talk about, essentially the keratoconus, for the most part, has been removed. So the success rate, particularly of the PRK procedure after a transplant, is quite good. We can consider this, if your vision is correctable with glasses, after removing the corneal sutures. We've also found even more use of the PRK procedure sometimes earlier in keratoplasty and transplant techniques when we use what's called the deep anterior lamellar keratoplasty technique, or a DALK procedure. This is a corneal transplant where we don't take all the tissue out. Rather, we leave the interior cells, the endothelial cells, in place, and rather just remove the tissue over and above this. In many cases, we start this using a laser, which can make particular conformations of the cornea to facilitate astigmatism and transplant control afterwards. And this is a scan of that type of procedure where we are removing most of the cornea, but you can see this wispy sheet here. We are leaving the interior cells in their normal position. This may facilitate transplant healing, allow us to get stitches out earlier, and make you amenable to, if we think appropriate, a PRK procedure to help improve your vision afterwards.